Hi, welcome. I'm Bill Cavanaugh from the Center for World Catholicism and Intercultural Theology here at DePaul University. We're delighted to have Sister Catherine Mulligan with us today. Sister Catherine came in yesterday to Chicago, and the coronavirus has unfortunately caught up with us, and we had the announcement last night that all events were canceled, all public events are canceled on campus, and so we're going to be doing this lecture in a little bit different circumstances in front of a live audience of just a couple of people, but through the magic of technology, this is going to go out through the rest of the world so we can all hear Sister Catherine's inspiring comments. Sister Catherine Mulligan is a daughter of charity, originally from Ireland, who's been working in Kenya now for 14 years and is coordinator of Project Dream, an innovative project in treating HIV and AIDS in Africa in conjunction with the San Egidio lay community as well. So, Sister Catherine, welcome to DePaul.
Thank you. So, thank you for inviting me here to speak to you. Thank you for coming to listen. And thank you for the nice introduction. So your lecture series this year addresses Vincentian responses to poverty around the world. Vincentian mission and service emerge from a particular Christian spirituality, a deep awareness of the gospel, a set of values, and an insight into the immeasurable dignity of every person, and altogether that puts the poorest of the poor exactly center stage. The DREAM program is one such response, and that's what I've come here to speak about, to present it as a Vincentian response. So DREAM is an acronym: Drug Resource Enhancement Against AIDS and Malnutrition. And the core aspect of the DREAM program is the care and treatment of people living with HIV and AIDS through the provision of comprehensive, high-quality care. This is done by means of administering a particular combination of drugs, commonly referred to as ARVs, together with the provision of different clinical interventions, good nutrition, and social supports. However, before I describe DREAM in any detail, let me tell you something about the origins of DREAM itself and how it came to be a Vincentian response. DREAM was developed in the late 1990s by the community of San Egidio, a young lay, at that time a very young lay community started in Rome, and they were involved in bringing humanitarian aid to Mozambique during a 12-year civil war. When the war ended, they began to say to themselves, what now can we do for Mozambique? What would be the most important thing? And at the time, Mozambique, like all of sub-Saharan Africa, was devastated by HIV and AIDS. So they decided, because many of them at this stage are qualified doctors and other medical practitioners, and they decided to devise a program that would combat AIDS and would bring the same kind of care and treatment into Africa as was available in the rest of the world. So this is what the vision they had and the promise that they formulated, that they would offer the same treatment and the same hope to patients in Africa as was available to people living with HIV in Western Europe and the United States, people who could afford to pay for care or who could afford through insurance policies. Now, to say that in the late 1990s about HIV in Africa was a huge promise and a big dream for them. So they set about devising that program, and they called it DREAM. And over the following years, they developed it and introduced it in Mozambique. They have probably 15 or 16 centres now in Mozambique, but they brought it in there. And after that, they introduced it into 10 other African countries. So it's quite widespread now, and it's a dream. It's a programme of quality and sets a standard within every country. So how did it become a Vincentian response? Well, Father Robert Maloney, who is a Vincentian priest and incidentally a trustee here at DePaul, was in Rome. He was Superior General and he was in Rome for 18 years, and he made great friends with many members of the community of Sant'Egidio. He was at many of their functions and participated with them in various services around Rome, and he heard a lot about Dream. And at some stage he raised the possibility with them that maybe the Daughters of Charity, who's a community founded alongside the Vincentians by St. Vincent de Paul, that they would collaborate with them and bring it into the countries in Africa where they worked and where they had the capacity to provide the programme, to deliver the programme. Because we work in 21 countries in Africa, but in many of them we wouldn't have the capacity to deliver a programme like this. We have a small presence, particularly in North Africa. So it had to be into the countries where we were already well established, had sufficient personnel and resources to provide the programme. So discussions started between the two communities, and over a period of 7 or 8 months, they hammered out an agreement, a collaborative agreement of what Sant'Egidio would provide in terms of the technical expertise and the oversight of the programme, and what the Daughters would do on the ground to deliver this programme. And a formal agreement was signed to that effect. At that time they set up a small committee to coordinate the development, because the Daughters of Charity had no involvement with Dream up until this, so we had a lot to learn and we had a lot of work to do to develop this programme and to bring it into Africa. So there was a coordinating committee set up, and Father Maloney was asked to coordinate that, and he still coordinates it to this day. There were 2 Daughters of Charity appointed, one Sister Jacqueline from the Congo. She was later replaced by a sister from Tanzania, and myself. I was actually working in Ireland at the time, but I knew I was going to Kenya in a year or so. And then 3 members of the Sant'Egidio community who were all doctors. So all of us came together, and we were given the task of coordinating and helping the sisters to develop this programme in each of the countries as we went into them, and then to continue to provide education both in country and in Rome, where a lot of the education is done. We were also joined, we have here in Detroit, we have an organisation it's called the International Project Service, and it raises finance for all the projects of the Daughters of Charity worldwide, not just Dream, but they became interested in Dream, so the director of that project, of that programme also joined the team, and the present director is Sister Mary Louise Stubbs, so she joins our meetings whenever we meet, and she has done a lot also to raise funds for Dream. So that was the beginning. There was a great synchronicity between the community of Sant'Egidio and our own community as we share, and the Vincentian community wider than just the Daughters of Charity. We share a similar spirit and charism, and both communities have a huge commitment to the poorest of the poor. The team meets in Paris every year, or sometimes in Rome. This year probably in either place, but normally we meet in Paris, and some members of our own General Council join that meeting. And then we bring 6 or 8 members of staff from each of the countries we're in to Rome every 2 years for an intensive training, because Sant'Egidio have, like here, they have enormous resources there from all of their years in doing this, and they have access to professors from the university who are very involved with Sant'Egidio, but are able to do the lectures and, I suppose, upskill all of us in all the new developments in the fight against HIV and AIDS. So what is a Vincentian response, and how is it typified by this, our adopted programme Dream? At the heart of any Vincentian response is the development of the whole person, promoting human dignity and working for justice. So Dream becomes multifaceted. It's not just a health programme as such, It reaches out to the families. We do social work. We try to do development work for them to put them on their feet, to try to get them out of poverty. So it's more than just a standalone health response. For us as Vincentians, living out our particular charism means seeing the world from the perspective of the people who are poor, being advocates for a more just society, living as people of hope, because some of the places we work in, they don't immediately engender hope, but we have to bring that hope, we have to find that hope amongst the people, and the people are very resilient for the most part. And we have to work with great compassion and love for the people we serve. This also involves cultural shifts away from one's own preferred options to meet people where they are, in a mutuality that respects and learns from those we serve and from those alongside whom we work. It's also a distinguishing mark of Vincentian work that we live among or close to those we serve, close enough to understand them, to understand where they're coming from in an experiential way, as far as that's possible when you're coming from a different cultural context. But we have to understand the challenges faced by them. Because we belong to religious communities or indeed to families, we have security and an education and a professional expertise that the people we serve don't have, at least at that moment in time don't have. So we have stabilising factors. So even if we say in some of our places we live amongst the poor or we live close to the poor, we still have security and stabilising factors that they don't have. However, we need to be close enough to experience and to form genuine friendships with them. So being there for the long haul is also a very important aspect of a Vincentian response. It's not a relief effort, and we see many people coming into Africa doing relief efforts, and much as relief is needed, especially after a disaster, and we engage with it when we have to in times of disaster. But a Vincentian response is long term, and you don't see results very easily or very quickly. You have to take the long view, look back over many years to see what's happening. Also for the Vincentian family, especially for the priests, the Vincentian priests and ourselves, from the time of St. Vincent and St. Louise, our founders, we learned and were encouraged to trust in divine providence and to allow ourselves to be led by the Spirit. So we don't have everything that we need when we start anything. We just start and somehow or another it develops, and that's true of most of the things we do. So trusting in divine providence is an automatic response for the Vincentian family when faced with people in need and with few resources to respond. And we've seen great creativity and miracles happen. And this project has been Spirit-led from the beginning. So to understand the importance of DREAM and the contribution it makes, a very quick overview of the challenge of HIV worldwide. So worldwide, 37.9 million people live with HIV and AIDS, but almost 2/3 of those live in sub-Saharan Africa. So it has hit Africa particularly hard, I suppose, because of the underlying poverty, the lack of health resources, the lack of education resources that isn't available in the West. That is available in the West. 32 million people lost their lives in the last 20 to 25 years to HIV, which is a big number of people as well. However, it's important to appreciate the great developments in care and treatment has also taken place through education and raising awareness and dealing with related stigma, which was very, very high and is gradually reducing. It is estimated that 79% of the people with HIV and AIDS know their status. Now that's a very good statistic because in turn it leads to care and treatment. It's estimated that 23.3 million people are receiving ARVs, which also is a good statistic. However, it also shows, the statistics show that 50% of children infected with HIV with the virus are not on treatment, and 38% of adults are not on treatment. So it's a mixed, there are gaps there, and that's what we're working to try and close, and what the global community is working at, not just us. The stigma of HIV and AIDS, particularly in Africa, creates enormous problems and makes disclosure of their status to partners or children very difficult, and that's one of the reasons why, you know, it's so slow to get all children on treatment or to get all people on treatment. They find it very difficult, and in some countries more than others. In Kenya it's not bad, but in some countries the stigma is horrendous. 20% of pregnant mothers who are HIV positive are not on treatment, exposing their babies to disease and potentially creating a cohort of children who would need lifelong care and treatment. The Daughters of Charity were working with the community of Sant'Egidio in Mozambique before we entered into this collaborative agreement, and they have one of the biggest centres that we have, with over 10,000 clients in it in Mozambique. But just under this agreement, we opened the next Dream Centre in Nigeria in 2007, and in the following 6 years we opened Dream Centres in Nigeria, Mozambique, Kenya, Cameroon, Congo, Tanzania, and 2 other centres are planned and are under consideration for the Congo and for Nigeria. So this was rapid scale up of services for the daughters in 6 years in all of those countries, because it involved training the sisters, training the staff who would work with them, and it involved in almost every country the building and equipping of a Dream Centre. In Nigeria and in Cameroon they have a hospital attached, so it was building a centre onto an existing hospital. But in all the other countries it was building new Dream Centres from the very beginning, with everything that was needed: a molecular laboratory, clinic rooms, nutrition places, everything that was needed for a Dream Centre. So it was very rapid scale up for the sisters. So the countries differ also very much. In the Congo, the Dream Centre is away in the northwest, an hour's plane journey from the capital. The plane only goes a few times a week. There are no roads because all the bridges have been blown up, and the only other way is up the Congo River, which takes 3 days. Now, for them to build a Dream Centre, everything had to be brought from the capital on open boats up the Congo River. So in Kenya, we're on the side of the main road. In the capital, no problem with building. So it differs from country to country what had to be done to bring Dream there. But the sisters and their staff have showed enormous courage in doing this and bringing it to the places where it was most needed and where there was no other service. So I'm going to speak a little bit about Dream Nairobi, because each Dream Centre is the same. They're all built on the same model, they all have the same protocols, they all provide the same treatment. So when you see one, you see all of them. So those of us who have to coordinate the Dream Centres are able to do that because it's the same model that exists everywhere. So we can, language is a problem, but we can go to one country or another country and know exactly what to do and be able to train staff there. The population of Nairobi is 5.1 million, and 36% of this population live in poverty and really difficult circumstances. They live on less than $1 or $1.50 a day, and that's from the World Bank statistics. This has improved somewhat, but people are poor not only in income, monetary income terms, but as a result poor in health, housing, adequate food, security, job opportunities, education or skill-based training or qualifications. And all these things put together make them almost unemployable. They don't have anything to offer. So they end up going around breaking stones for people who are building walls or building houses or doing very menial work. The women go from house to house of people who are well off, often the non-Kenyan population, taking washing or sewing or things like that to do for them, but it's all very menial work. These factors perpetuate a cycle of poverty, and of course children suffer most. They suffer most of the consequences, and many children are hungry every day. Many people gravitate towards Nairobi, and I suppose that happens in every country that experiences poverty. People think if they can get to the capital there will be work, and there isn't work, and certainly there's not work for unskilled people. So unemployment is high. And it was in this scenario that we started to look at what we could do. When the sisters first arrived in Nairobi in 2004, two of the services we offered was a mobile health clinic, because there wasn't any such thing around and there were very poor health facilities. And we also did a women's empowerment project. So there were the two things. But the more the sisters went out with the health clinic and the staff, the more they came up against HIV and AIDS. Now, this is before we met Sant'Egidio or knew anything about DREAM. So they knew that this was a huge problem. So when Sant'Egidio and we entered into this agreement, they were very, very enthusiastic to start and to build a DREAM centre and to provide a quality programme in Nairobi. And that's what we did. But before we did that, they did a second survey within a 10-mile radius of where we live to see what was available. And there was lots of places people could go to be tested, receive a certain amount of counselling, and then they would be referred to a clinic or a hospital. If they never turned up at the clinic or hospital, nobody followed them up. It was up to them to go. And of course they're frightened, the stigma was very high, so they would forget about it or just not go. So that was one thing that prevented them receiving any kind of treatment. The hospitals had a certain, I mean, there are some good private hospitals and some good mission hospitals around Nairobi, and even the general hospitals under the Ministry of Health. They would provide ARVs and treatment, but they didn't do the extra things. So DREAM, in the way it was designed, also insisted that we look at everybody's nutritional status, give them the nutrition that they needed if they needed it, that we would target the mothers so there would be no transmission of the virus from mother to baby, and that we would have a home-based care team, and we would train activists or volunteers who are people who are HIV themselves but have learned a lot about the disease, are compliant with all the treatment and therefore well, and they infiltrate, is not a good word, but infiltrate the areas where they live to support others who find it hard to come out, hard to face the stigma, hard to come for treatment or whatever, and ensure that they come. And you know, they're everybody is very sensitive, of course. When people are poor, they're hugely sensitive to what other people will think about them and their poverty, and then HIV on top of that. So even we have a vehicle that goes out every day with a home-based care team, but we had to take the DREAM Centre logo and the name off it. We had it painted, but the clients themselves objected to it coming into an area, because then people could identify who they were going to see and why. So we had to be sensitive to that. The advantage of having the volunteers there is that they're people from the area and they're very discreet, and we train them and we pay them to do this work. So not a very big, not a salary as such, but a stipend that keeps them going, and we give them baskets of food from the nutrition. So when we did that survey, we discovered that all these things were missing, that DREAM could provide, and that it would make a major contribution, focused intentionally on people who were poor, and that DREAM would be a model for a high quality programme in Nairobi, and that's what it became very quickly and very early on. Many of the things that we and others in Nairobi and elsewhere take for granted today was put in place by DREAM early on, before anybody else. And for example, with the pregnant women, at the time we started DREAM, and when we were discussing it with the Ministry of Health and trying to get a contract signed with them, they had grave concerns about us pushing mothers on treatment at 12 or 14 weeks, because they said it's too expensive, we can't replicate it, you're setting a standard that nobody's going to be able to reach, and it's not necessary or whatever. At that time, it was reckoned that 40 to 50% of the babies born to HIV positive mothers were positive at birth. In the 12 years we've been delivering this program, we've had no baby born positive. There are 4, I think, babies in the program who were born positive, but the mothers either came at the very end of their pregnancy or after they delivered and discovered that their baby was positive. But for those who were put on treatment and who were compliant, nobody has been born in that time. But today, everybody's doing that. Now, we can't take credit for that because the global community puts huge pressure on Africa, whether it's the World Health Organization, the Global Fund, UNAIDS, the PEPFAR funding, CDC here. Everybody is pushing pressure because they're giving money and they're able to say, this is the standard you have to reach, or you get no money. So, I mean, we're proud of our record, but external factors to us also scaled up the program very quickly. We have currently 3,000 clients in long-term care, but as I said, care also extends to families to help them become economically more secure and healthy. The DREAM program targets people with a low socioeconomic status, and we got somebody to do a survey for us of all the clients, and it came out that 81% of the DREAM Nairobi clients are either unemployed, casual labourers, or run small precarious business, but most are very poor and struggling. And many employers, even today, even though the law forbids this, I mean the law in Kenya is good around all of this, but they won't employ people. And we have to open the clinic earlier and earlier every morning. We open, sometimes the clients are there at 6:30, when the normal time for opening the clinic would be 8. But we've had to start earlier and earlier because they want to get to work and they don't want their employer to know, like once a month they have to come for treatment and for drugs. So we have to meet that need in them, so they're not taking time off work and nobody need know that they're HIV. They would lose their employment. It wouldn't be overtly for HIV, but they would find ways of getting rid of them. So the stigma is there, but also the unfounded fear of infection. I mean, they think they can get infection from using the same cups or something like that, which is nonsense, but that's the way they feel about it. So to minimise the barriers then to healthcare, all the services are free to the HIV clients. Now our funding organisations put a lot of pressure on us about that, because they say, how are you going to sustain it into the future? You have to start charging people. But you know, if you start charging people who can't afford to pay, they just won't come, and then you have a new cycle and new strains of the virus. So that's not. So from the start, DREAM offered the following services to clients: provision of HIV counselling, testing and psychosocial support. We have a medical laboratory at every DREAM centre, so we're able to do all our own laboratory testing. The provision of ARVs, medication, nutritional assessment and food supplementation, and there are particular groups of people we target for that. Maternal and child health services. Tuberculosis is a very big complication of HIV, so we provide tuberculosis screening and treatment, provision of home-based care services that I've spoken about, support groups for people living with HIV, and I'll say a word about those in a minute, and continuous education and work towards preventing HIV infection and eliminating stigma. And in the last couple of years we've introduced cervical cancer screening, because cervical cancer is very prevalent in women who have HIV. So we screen all women between the ages of 18 and 65 every year. The same people are screened every year and then referred for treatment. And there is a National Health Insurance Fund in Kenya. It's not great, but it's something. And often we pay this, the person has to pay a subscription every month into that. So one of our ways of coping with the poverty is to pay that subscription for the really poor people, and especially if they have to be referred for treatment, then they can avail of treatment free. If they're doing it themselves, they always default on it, and then when they go looking for treatment, they have to pay for 3 months before they're eligible again to get anything free. So we try to keep an eye on that for them. We also try to make Dream a one-stop shop, so we treat other things that the client may have, opportunistic infections, high blood pressure, diabetes, depressions, because the mental health issues are a big part of it. We provide psychosocial supports, and we do all the childhood vaccinations for children. Just a word about counselling. Counselling is particularly delicate for all the clients. All the clients are counselled themselves about HIV and treatment, and they receive personal support. But they're also encouraged to bring their partners for testing and for support, and they find that very hard, particularly for the men, because often they have got HIV when they were already in a stable relationship with whoever their current partner is. So telling the partner they're HIV and all of that, and probably more dangerous for women because of the gender-based violence if they become HIV while they're in a stable relationship of whatever kind they're in. So it can be very difficult for them, and of course they're highly contagious and infectious at that time. Then we also ask them, and this is also, I'm thinking of it now with the coronavirus, when they're trying to trace everybody that ever touched anybody, we also try to trace former partners or current partners. They may have other partners beside the one they're living with and supposedly committed to, so there may be other partners and former partners, and that's particularly difficult because those partners don't like or appreciate getting a phone call about a relationship they had 10 years ago with somebody who's HIV now and asking them to come for treatment or to be tested in case they're HIV. But it's trying to break that cycle, just as we're doing now with the coronavirus here, even though it's very different, but trying to break the cycle. But the staff take a lot of abuse on that particular issue when they're in these people, as you can imagine. Kenya's young people, especially the adolescents, are a particularly vulnerable group, and they have certain needs that we have to take care of. In Kenya, nearly 18% of adolescent girls between the ages of 15 and 19 are mothers. So that's a huge percentage. The rates of adolescent childbearing are higher amongst the poor or people with lower levels of education. And those that are in school drop out as soon as they're pregnant. They're very vulnerable to gender-based violence, and they're often ostracized by their families. So we have, as soon as we know that, we have to begin working with the family, inviting them into the clinic, explaining that the person can live a normal life, that we will protect the baby from being born with HIV, all of that, and trying to give some social support to them and a lot of counselling. And that works because our staff are very, very competent at doing that and very concerned and very compassionate. They're all Vincentian qualities. But I mean, they really do that very well to try and keep the child in school, get the young mother in school, get someone else to look after the baby until she finishes her school and her exams. And we've had many success stories along that particular road. So, I mean, any more than in any country, and we all believe that education is the road out of poverty, and it provides possibilities for employment. So keeping them in school is a very big part of the young people's what we do for them. We also have many support groups that meet at weekends. Each support group usually meets once or twice a month, and at least one clinician or staff member is present at every support group meeting to give confidence, to answer questions, to allay fears, all that kind of thing. We have separate groups for men, women, adolescents, children, mothers with babies, discordant couples where one is positive and one is negative, and for same-sex partners. So all these groups meet at the weekend, they get lunch. The clinic is closed to ordinary business on a Saturday, so the groups are meeting. And fear of disclosure is very real, especially among school-going children and adolescents, because if their HIV status is known, they can be bullied, there's name-calling, people shame them into all of this. And of course they're trying to deal too with the fact that they got the disease from their mother. And that creates a lot of adolescents are very angry, so we do a lot of intensive work with adolescents. They're ashamed, that's the basic thing, and it's a confusing time for them, and it leads to a lot of low self-esteem, suicidal thinking, and it means they find taking medication difficult, so they hide it or they throw it away, and of course that defeats the whole purpose because they get very sick very quickly. I said about the nutritional status of our clients, it's often poor because of their social situation and then because they're sick. And HIV drugs are very hard to take, they're very toxic. I suppose newer drugs are less so, but I mean a lot of the drugs, if you're not well nourished, are hard to take and they give up. So at each visit, all eligible clients receive a basket of food supplements containing maize flour, beans, sugar, milk powder, cooking oil, and a special combination of cereals that we make up ourselves at the centre to make a nutritious porridge. So they go home with that, and malnourished children receive plum peanut, which is a high energy peanut paste that contains sugar and vegetable oils and vitamins and all of that, and very easy for children to take. The home-based care goes out every day, and they're linked into the activists or volunteers who keep them notified of who's sick and where to go, and everybody has mobile phones, so that's one thing in Kenya. In the remotest parts of Kenya and indeed all over Africa, people have mobile phones, and there are masts up everywhere to give cover. So it's easy to contact people, and it's easy to contact people who default, who don't, at the end of every clinic, they go through all the people who should have come and didn't come, and then phone them and phone them again the next day and phone them until they come, or send the clinic out, the mobile clinic out to see what's going on. I just put this up, it's the budget, just to show you something of where it comes from more than what it costs, because it's a very expensive program. In the context of Africa, it wouldn't be an expensive program here. But our main funders are CDC from Atlanta, with the PEPFAR fundings. And the PEPFAR funding is the program set up by President Bush when he was president to work against AIDS. And it's called the President's Emergency Plan for AIDS Relief. And it's wonderful that it has survived the president since, and everybody's praying it'll survive the president now and into the future because CDC has had their budget cut. So, but we get a lot of money, and it comes to us through the University of Maryland. And the way that happens, every couple of years, CDC they look for tenders for who can provide this program for, you know, maybe 20 other service providers. So they have to have the capacity to provide and to supervise and to be accountable for the money that goes to all these other smaller service providers. So when we first started, I've forgotten who we were with first, then we were with CRS, Catholic Relief Services, then they pulled out of it, and then the University of Maryland got the tender the next time, and we don't know who followed them or whether they will continue to get it, but they have been absolutely wonderful partners for us. They have big offices in Nairobi, and we work with them all the time, and they're in and out of the centre, and they have taught us so much, and we've learned a lot about the disease, but also about program management and accountability and all of that. They've done great. And then Irish Aid, Mishinkara is a limited company of Irish Aid that gives money to the missionary groups, and they support us. The International St. Vincent de Paul give us money for nutrition. The DC International Project Service, working out of Detroit, raise money for us, and sometimes much more than that. This is last year's budget, but 2 years ago the International Project Service raised 180,000 for us to put solar into the whole, so everything is on solar in the DREAM programme. As a movement towards sustainability for the future. We have a Dream Fund in Paris that we can draw money from, and we get donations from the Development Office in Dublin. So we also receive free. I mean, that's about half the cost. We also receive free. If we had to pay for this, it would double that cost from the Kenyan government agencies, test kits, the ARV drugs, and some non-ARV medicines, some nutritional supplements, and some laboratory support with reagents and testing. So there's so much more that could be said about DREAM. Its comprehensive and collaborative nature, that's what makes it unique. It's embedded in the national health system, so we're a vital part of the national health system, and we have done that in every country. It's greatly respected, and we had an external evaluation from Irish Aid last year, and the evaluator asked the representatives from the Ministry of Health to rate DREAM, and without hesitation he said, they said 9 out of 10. So that was a big thing for us. The other day I was coming through LaGuardia Airport, and I picked up Time magazine because it had the 100 women, most famous women. But this is what struck me, a quotation from an article here. It's easy to forget today that what pariahs people with AIDS were in the year 1987. Ignorance, superstition, and an aura of sexual seediness swirled around those afflicted, their cause of death noted in obituary columns with a vague lack of specifics that protected their relatives from opprobrium. Now that was referring to the UK, and the same was true of the United States and Western Europe. That's only 23 years ago. So while we're talking about Africa, it was a global phenomenon at that time and a global challenge. And I suppose what makes the difference is having access to health care, to education, to funding. So just to finish, Pope Francis calls us all to a globalization of charity to respond to global challenges. And 20 years ago, HIV and AIDS was one of those global challenges. But today, thanks to an effective global response, of which DREAM is proud to be an active participant, the person living with HIV and compliant with medication can live their life, albeit with drugs and other supports, but they can live into old age and probably with greater security than many people with other health issues. The programme reaches those most in need in a caring, compassionate way and is non-judgmental. The clients always speak of the friendship and welcome the experience. The staff embody Vincentian values, and we do programmes with them to inculcate those values and to help them articulate them, because the people who come to work in that kind of work already have those values. You know, we're only just trying to give voice to them. But things like respect, compassion, hope, integrity, empowerment, and to be advocates for justice, to make sure that the clients get. And these are all at the heart of what it means to be Vincentian, and together with the sisters and all those who partner with us, makes a remarkable Vincentian response to poverty. Thank you.